In this session, we will be discussing about dural tears. So first, let us know about the cerebrospinal fluid, the anatomy and the relevant physiology. So we all know that the majority of CSF is produced from within the two lateral ventricles in the brain. From here, the CSF passes through the interventricular foramen of Monro to the third ventricle and then the cerebral aqueduct of Sylvius to the fourth ventricle. From the fourth ventricle, it passes through foramen of Magendie on the midline and through two foramen of Leschka laterally into the subarachnoid space. You can clearly see here. So this is the interventricular foramen of Monro. From here, this comes here, and through the cerebral aqueduct of Sylvius, it comes here, and from here then it goes through foramen of Magendie and Leschka into the subarachnoid space, and then it drapes the entire spinal cord. So this CSF, after going through the entire spinal cord, it returns to the vascular system by entering the dural venous sinuses via the arachnoid granulations. And this CSF flow along the cranial nerves and spinal nerve roots allow it into the lymphatic channels. So it is produced at a rate of approximately 0.3 ml per minute or about 20 ml per hour for a total of approximately 450 ml per day, and the CSF turns over about 3.7 times a day. The average pressure is about 10 to 18 in supine and 20 to 30 centimeter of water in sitting position, and globular proteins and albumin are usually in lower concentration in ventricular CSF compared to the lumbar or cisternal fluid. So why is this dural tear important, and why do we want to discuss about this? Because in spine surgery, one of the common complications that we encounter is the dural tear or the CSF leak, and it is one of the commonest condition for which medico-legally the doctors or the surgeons are held liable. Okay, so this is why we have to know what is dural tear and how to deal with these dural tears. So basic definition wise, a durotomy is violation of the integrity of the dura, but more commonly it involves a breach of the arachnoid as well, which produces a CSF leak. So we all know that there are three layers of meninges. One is the pia, the innermost is the pia mater, then comes the arachnoid mater, then comes the dura. So the dura is the entire covering layer, especially in the lumbar spine. When we are operating below L1, it is nothing but the dura with the entire rootlets along with the other layers of the meninges. The dural layer is usually a thick layer. So whenever there is an injury to the dura or a dural tear, invariably the arachnoid gets injured because the arachnoid is a very thin flimsy layer. So and the subdural space also is not very well formed space. Usually the arachnoid is along with the dura. So whenever there is a dural tear, it will injure the arachnoid, resulting in a CSF leak. The CSF which is present between the arachnoid and the pia mater comes out. And what is dural rent? Dural rent is nothing but the presence of dural violation with an intact arachnoid. So only the dura is gone, so the arachnoid with the CSF will bulge out. What is pseudomeningocele? Pseudomeningocele is nothing but post-operative, usually it is post-operative, extravasated collection of extradural CSF that communicates with the subarachnoid space. So there is subarachnoid space and CSF, the CSF comes out of the subarachnoid space, and it is a collection which can be in the subcutaneous tissue or at the submuscular plane, basically through a breach in the arachnoid and the dura. What is the difference between a pseudomeningocele and a CSF fistula? When the extradural CSF, that is the CSF which is coming from the subarachnoid space, communicates with another cavity, or when it communicates to the exterior through a defect in the skin, it is called a CSF fistula. So what is the incidence? The incidence of durotomy is about 2% to 17%, and it is about 2 to 4% in case of primary discectomy. However, the incidence of durotomies or dural tear is about 13% in case of revision discectomy or revision procedures. And when we are dealing with spinal canal stenosis because of thick or adherent ligamentum flavum, the incidence can go up to 8 to 9%. What is the etiology? The commonest etiology is surgery. So because usually they don't get exposed to any other traumatizing agents or factors. So surgery is the commonest cause, followed by trauma. Trauma itself can cause injury to the dura, and in high grade injuries with spinal cord lacerations, you can see dural tear with the rootlets coming out. Or it could be congenital, or lumbar puncture very rarely can result in pseudomonas heals or CSF fistulas. Dural puncture during myelogram or epidural catheter, all these things can result in dural tears. It is common in which group? It is usually seen in elderly patients, because the dura will be very thinned out in elderly patients. The ligamentum flavum will be thickened and adherent to the thinned dura, and it can be seen in infections. Again, the dura will be thinned out and altered in infections. Tumors, yes, of course, because the tumorous tissues can invade the dura, it can pass through the dura into the spinal cord, or it can cause compression of the dura, making it very thin. Severe stenosis, as we already discussed, severe stenosis results in thick ligamentum flavum, and this thick ligamentum flavum can be adherent to the dura. This adherence of the ligamentum flavum to the dura can cause dural tear when we are trying to decompress the dura or the spinal cord. Malpositioned implants, like for example a malpositioned spinal pedicle screw. When you are inserting a pedicle screw, the pedicle screw can breach the medial wall of pedicle and can enter into the spinal canal and damage the dura. Again, thickened and adherent ligamentum flavum.